Welcome everyone to this Touch Cases activity on optimizing early detection, risk stratification, and treatment decision making in PAH. I am Dr. Athénaïs Boucly. I'm affiliated with the University of Paris-Saclay in Le Crâne-17, France. And I'm delighted to be here today with Professor Pilar Escribano Subías from Madrid, Spain.
Hello, everybody.
So today we will be discussing 3 clinical cases of pulmonary arterial hypertension, exploring their presentation, diagnosis, and management strategies. And I'm going to start with the first case, who is a young patient, 32-year-old woman with unexplained fatigue and dyspnea that has become more evident in the past 6 months. So this young woman was diagnosed with an asthma 15 months ago. The asthma was suspected and she was treated accordingly. She was very active previously. She did hiking and cycling, but she stopped everything 3 years ago because of dyspnea. She was treated for asthma, but she was still very dyspneic, and that's why she consulted her GP again and again. And finally, her symptoms were still there. That's why she was referred for new appointment, new workup, and a pulmonologist prescribed pulmonary function tests. The pulmonary function tests were normal. She had normal FEV1 on FVC. She doesn't have a clear diagnosis of asthma, but she was still very symptomatic with breathlessness. And we also found that she has a puffiness around the ankles. So with asthma now occurring less likely, it's important to consider alternative diagnosis and to refer the patient to a specialist, either pulmonologist or cardiologist. So the question is, when should PH be considered? So the question, Pilar, is what are the early signs that provide important clues?
Yeah, perhaps, like always in a patient, perhaps we need to think about the patient. What is the background? The patient have other diseases. For example, the patient have scleroderma, or the patient have a childhood operation for congenital heart disease, or the patient have other family members who suffer from pulmonary hypertension or from unexplained dyspnea and early death. This is cool. This is very important because it's like a red flag that perhaps we are in front of a patient who have pulmonary hypertension. At the same time, it's important to put together the dyspnea and the peripheral edema. That is another important clue to perhaps think about pulmonary hypertension. And in the GP, we can get easily an electrocardiogram. If we have a right axis deviation and dyspnea, is increasing the possibility that our patient have pulmonary hypertension. Or if we can get pro-BNP, is put together with the signs of the electrocardiogram and the symptom of the patient. This is the system to is going to the possibility to have the diagnosis of pulmonary hypertension. If we have this suspect, we need to refer the patient to be studying them.
So if I correctly understood, the symptoms of pulmonary arterial hypertension are very common, and it's difficult to make the difference between asthma, other diagnosis, cardiologic diagnosis, and pulmonary hypertension. That's why the diagnosis is often delayed, right?
Yeah. That's the problem. That's why it is important to put the symptoms together because the asthma doesn't produce peripheral edema, and in this system, it's a good point to have relationship with the symptom and the most basic test. But the truth is that everything is very inspecific, and the delay in diagnosis is a reality nowadays.
Thank you very much. It's very interesting. So GP are an important point of referral. So let's ask the audience. Please tell us what initial testing in primary care can help to make a diagnosis of PAH in this patient. So Pilar, I have a new question for you. What is the role of ECG and other more intermediate states such as echocardiogram? You told us about ECG. So When do you perform echocardiogram in evaluating symptoms? When is it so important?
When you suspect with the symptoms of the patient or with the electrocardiogram or with the chest X-ray that the patient could have pulmonary arterial hypertension, I perform an echocardiogram because this is a very important clue in the diagnosis of pulmonary hypertension. Because we are going to see some signs that are evident and typical for pulmonary hypertension. All of us have in mind the tricuspid regurgitation velocity that permit calculate the pulmonary systolic pressure. That is obviously very important to focus the diagnosis of pulmonary arterial hypertension. But we have at the same time indirect signs of pulmonary arterial hypertension. For example, the right chambers, right ventricle, and right atria is bigger than the left ones. We have tricuspid regurgitation and other signs that can help us to evaluate the possibility that our patient have pulmonary hypertension. And at the same time, we can exclude some of the most common left heart disease.
Okay, that's particularly interesting because this is exactly what our patient had. I would like to show you some information regarding the workup because we have discussed the diagnosis based on the symptoms and we have to suspect pulmonary hypertension, but we can be helped with a workup including cardiologist and lung assessment. So we will perform echo based on the clinical suspicion, but we can also perform other tests such as pulmonary function test, chest X-ray, sometimes chest CT, CPET, and VQ lung scan in order to make a diagnosis, but also to rule out some other diagnoses. So according to ECHO, which is a very important screening test, we will assign a probability to have or not having pulmonary hypertension. So this is an echographic probability. And then we will perform the only tool which is able to make the diagnosis. So I'm talking about the right heart catheterization. So right heart cath is very important. And this is also important to remind you that in some cases, patients may have a rapid progression of symptoms, a high suspicion of pulmonary hypertension, and in this specific case, we have to refer very quickly our patient to a specialist of pulmonary hypertension in order to perform quickly right at cath. So, if I come back to Louisa's case, I would like to tell you that she has exactly what you described, Pilar. So, our patient had a dilation of right ventricular chambers, right RV, but also right atrial, and she had a high probability of pulmonary hypertension based on the echo, especially because she had a high level of tricuspid regurgitation velocity. So, this is the result of our patient. She had a high suspicion of pulmonary hypertension based on the echo. That's why we performed right heart catheterization. And we found a right atrial pressure of 16 millimeter of mercury, high level of mean PAP, 47. She had a very low cardiac index, 1.8, very high pulmonary vascular resistance, 13. She had a precapillary pulmonary hypertension because the wedge pressure was normal, less than 15. So she had severe pulmonary hypertension based on echo, but we also performed non-invasive assessment, including functional class, which was 3. She walked 320 meters in 6 minutes, and we also measured the biomarkers NT-proBNP, which were very high, 2,600. So she was very severe, and we also performed during right at cath testing the nitric oxide testing, which was negative. So she had precapillary pulmonary hypertension, non-vasoreactive, with severe functional class, wall test, and BNP. And we also, of course, performed all the tests, including angio-CT, VQ lung scan, autoimmune profile, and also liver echo. All this workup was normal. So we diagnosed a PAH. So the question now is regarding the therapy. And if we want to choose the right drugs, we have to assess their risk status, and we will classify our patient between low risk, intermediate risk, or high risk of death. So I have a question for you. Let's ask the audience. Please tell us, what do you think Louisa's risk status is? So do you think she is low, intermediate, or high risk? So we know that risk assessment is very important to assess the severity of pulmonary arterial hypertension, but also to for the prognosis and to guide the treatment strategy. So, Pilar, I have a question. Which variables are used to calculate the risk status?
The diagnosis, we need to be very accurate in the prognosis assessment, and we are going to use a lot of variables. Sure that we are going to use NIHA functional class, Ibrigues test, and NT-proBNP, but right here catheters have an enormous value at the diagnosis because in this patient we can see that he is in a high risk. He has heart failure with high right atrial pressure and low cardiac index. This is a clear sign of a very high risk for in the point of view of the prognosis. And the echocardiography can help us too in this initial diagnosis because give us the opportunity to see the remodeling of the right heart, probably in this patient with tricuspid insufficiency and so on.
So thank you. It's very important to consider all these variables together, especially at baseline, both non-invasive variables, but also invasive hemodynamics measurements, right atrial pressure, cardiac index, troponin index, mixed venous oxygen saturation. Echo is also important. So this is very important at baseline for sure, but I would like to remind you that it's also important to reassess the risk status of the patient during follow-up using exactly the same variables, functional class, wall test, BMP, plus hemodynamics, which is very important, especially if the lowest is not achieved at follow-up. So thank you so much, Professor Escribano, for this very interesting discussion. And I would like to remind you the most important learnings that we had. So first of all, symptoms are not specific to PAH. The second point, I will say that non-invasive tests such as echocardiography are very important as screening tests, but only White Cat is able to do the diagnosis of pulmonary hypertension. And finally, once the diagnosis is established, it's necessary to assess the severity of the disease and to calculate the risk status of our patient in order to choose the right treatment. Thank you very much. We will now discuss management of PAH with two cases. We will come back to our first case, Louisa, and we will also discuss Kurt, a 55-year-old man who has just been diagnosed with PAH and who is in functional class 3. So, if you remember, Louisa, 32 years old, she has a PAH and she was at high risk of death at diagnosis with very severe hemodynamics. And the question is, how should we treat this patient? So we know that treatment in PH should be matched to risk status, and the goal is to achieve a low risk status at follow-up. Louisa was at high risk of death at baseline, so which treatment should we choose for this patient initially? This is a question for you. You can vote. So I think this case was very simple, very typical case with a patient at high risk of death. So initial treatment option, if we come back to the guidelines and the treatment algorithm, we have the choice between dual or triple combination therapy. So Pilar, I have a question for you. When do you prescribe initial triple therapy?
This is the perfect clinical case to show the indication on triple combination therapy with intravenous prostacyclin. This is the perfect case, but because the patient has severe hemodynamics, very bad exercise capacity and heart failure. But perhaps we can find another patient that have severe hemodynamic, is very young, no comorbidities, that is in the intermediate risk, a little bit close to high risk, but not clear in high risk. In this type of patient, I prefer to use triple combination therapy because it's very important to be aggressive at the beginning of the disease. And then, if the patient is going very well, we can desescalate the treatment. But when the patient is so severe and in high risk or intermediate risk, but with severe hemodynamics, with severe right ventricular function in the imaging, it's a good option to begin with triple combination therapy.
Thank you. Very clear message. Thank you so much. So let's move to the second case, which is a bit tricky. So Kurt is 55-year-old man, and he has just been diagnosed with PH, as I said. He's in functional class 3, and he is at intermediate risk status. So this case is less typical, regarding the treatment management, because he has some comorbidities, including diabetes, hypertension, dyslipidemia. Hopefully, he is non-smoker, but he has a PH plus cardiovascular comorbidities. He is obese as well. And if we look at his severity, he is in functional class 3. He walked 220 meters, and TPOMP was high, 800. The DLCO was 70%. The CT was normal, at least there was no emphysema, but right cut was severe, mean PAP 40, wedge pressure 11, cardiac index 2.4, right atrial pressure 9, PVR 7 wood unit, and the mixed venous oxygen saturation was 62%. So we classify this patient at intermediate risk of death. So how should we manage this patient? While Louisa highlighted the challenge of early diagnosis, Kurt presents a different problem because he has PAH but also some comorbidities. So how to tailor initial treatment when comorbidities complicate the picture?
And in these cases are very, very important that the first step is to be sure about the diagnosis. When you have comorbidities, cardiovascular comorbidities, you need to rule out that the patient have heart failure with preserved ejection fraction and have pulmonary hypertension associated with this group. That means that we need to review in detail the echocardiogram, see what is the right atria is bigger than the left atria is not dilated, the patient don't have in the background atrial fibrillation, all these details that increase the risk of the patient have heart failure with preserved ejection fraction. And then when we are going to manage the patient, we always need to remember that we need to be aware of the diabetes. We need to keep under control the diabetes. We need to keep under control the hypertension, and we try to perhaps modify the way of life of the patient with loss and be more active.
So now a question for the audience. Which treatment would you choose for Kurt? So for a patient like Kurt with more complex needs, it's important to balance, as you said, efficacy, tolerability, and also personal preferences when choosing initial therapy. So as we discussed with Louisa, we have a number of initial options, which are double therapy or triple combination therapy, including IV or soft prostacyclin. But we also have to consider everything. We have to consider the patient as a whole. So I would like to remind you that if we want to consider dual or triple combination therapy for patients, we can combine some drugs together. And you all know that we have different drugs that target either the endothelin pathway, which is targeted by endothelin receptor antagonist. We can also target the nitric oxide pathway using PD5 inhibitor or solute guanylate cyclase stimulator. And we can also target specifically the prostacyclin pathway using prostacyclin analogs or prostacyclin or selexipag. So we can target either the nitric oxide pathway, the endothelin pathway or the nitric oxide pathway. So we can combine the drug together. Some of the drug have side effects. So I think it's very important to also consider and to tell the patients that it can develop some side effects due to the drugs. So what do you think? How do we balance efficacy and safety with patient needs when selecting treatment for care, Pilar? What do you think?
I believe that we are sure that this patient it's mainly precapillary pulmonary hypertension. Perhaps we can choose a combination therapy, a double combination therapy, but we need to look very closely because we need to be very, very cautious with the secondary effects. Because perhaps in this patient who have cardiovascular comorbidities, it could that have some degree of edema, and this is it could be necessary to adjust diuretics uh, for the patient. That's mean that we need to follow very closely the patient. Perhaps it's not so severe than the first one because the first one is a classical pulmonary arterial hypertension, high risk, and in all of us it's very dangerous. But this is a patient that is very tricky because we need to follow very closely. We need to explain him what is the meaning of pulmonary arterial hypertension, that it's very important that they take the pills properly because he has other diseases, other comorbidities that is necessary to control.
Thank you. So, how important is patient education to support adherence to their medication?
This is very, very important. And in this case is perhaps the key of the treatment of the patient. He need to understand what is the meaning of pulmonary hypertension and he need to understand that he stops suddenly the treatment of pulmonary hypertension. He is getting worse very quickly because he need to take a lot of pills, and in the end, in some occasion, the patient play with the pills. I go to take these pills, but this other no. And okay, for us, it's like an obligation to simplify always that it's possible the treatment of the patient, and we can choose, for example, a pill with a combination of PD5 and endothelin receptor antagonist. That's it. We can give two drugs in only one pill. And in this type of patient that need a lot of pills, it could be something that it's helpful. But we need to explain them, and we need to explain the caregivers that in a lot of cases is something that is have the age on the treatment of the patient and help him to follow the instruction of the doctor.
Thanks. So, after treatment initiation, we need to follow up and to reassess our patient for sure to reassess treatment response. So, what is the optimal timing for reassessment?
Probably there are two different points. One is the reassessment, and perhaps the optimal timing is 3 months. But in this type of cases that have cardiovascular comorbidities, is it possible? It's a good point to have a contact with the patient, at least a telephone call, a 1 month, to see if do you have a problem with the tolerability, it is truly following the instruction, and so on. Because if the patient have problem with the drugs, perhaps he stop or don't follow, and 3 months it's a long time. That's why to reassess 3 months, to have a contact with the patient in 1 month is a good point.
Thank you very much for this very interesting discussion. So, if we have to take in mind some messages, I would like to remind you that risk stratification guides treatment strategy, but we also have to consider the patient as a whole and to consider especially his comorbidity in order to explain him what are the expected benefits of the treatments, but also the side effects in order to reinforce the adherence of the patient regarding the therapy. This is very important. And it's also very important to consider symptomatic therapies such as diuretics, which are very important in the management of patients with PAH. So thank you very much. So we will now discuss the case of a 63-year-old woman with connective tissue disease associated PAH. So Juliana, 63 years old, she is a female, and she has been diagnosed 3 years ago with systemic scleroderma associated PAH. And at that time, she was at intermediate risk of death. She has been reassessed recently. She was treated with ERA plus PD5 inhibitor. And at time of reassessment, she was in functional class 3. She was 280 meters. The NT-proBNP was 700, and we performed the right at CAT. The mean PAP was 44 millimeter of mercury, right atrial pressure 9, wedge pressure 6, cardiac index 2.4, and PVR were 8 Wood units with a mixed venous oxygen saturation of 66%. So if we calculate the risk status, we can classify the patient at intermediate high risk of death, and she was still very symptomatic. That's why we have to reassess the treatment and to consider treatment escalation. So, Pilar, this is a patient with systemic scleroderma PAH. So, how do these patients differ in their presentation compared to patients with idiopathic PAH?
Uh, we need to recognize that here we have two different scenarios. One is the patient who is get the diagnosis in a screening program that we have an early diagnosis and the prognosis of this patient and the management is easy. But in the other hand, we have the other patient who is diagnosis from pulmonary hypertension because he is deteriorated, have dyspnea and so on. And in general, scleroderma have a more aggressive disease and rapid progression. And in this case that we are covering now, this is the typical situation. The patient receive a double combination therapy but fail because in the reassessment the patient have heart failure and very bad functional class and very bad exercise capacity. This is the black face of the scleroderma. That means that we need to be very aggressive to avoid the progression of the disease.
So, in terms of monitoring patients, this patient remains at intermediate high risk despite combination therapy, ERA plus PD5 inhibitors. So, this may be an indication for treatment escalation. So, I have a question for the audience. Please tell us what will influence your decision to escalate treatment here. So, what might be the clinical indicators influencing whether to escalate treatment or not, Pilar? Can you tell us what is the most important thing for you?
For me, the most important sign is the appearance of heart failure. When the heart failure appears, you need to be sure that you need to escalate and you need to manage very aggressively the treatment of the patient. The second one is when the similar test is going down. It's because it's not improving, it's not worse and worse in the reassessment. This is an alarm, a clear alarm. And then we have the images, the image of the right ventricle that in the scleroderma have in general a worse right ventricle than idiopathic pulmonary arterial hypertension that can help us to discover that the patient is going bad. And obviously, if we have that, because perhaps it's not clear, then the non-invasive test and the clinical of the patient, it could be a good point to repeat right heart catheterism to have the enough information to take the more accurate decision in the treatment adjustment of the patient.
I have a question, maybe a bit tricky, Pilar. Sometimes you consider as a physician that the patient needs treatment escalation, but he doesn't want. How do you manage it?
This is tricky, but in these cases, you need to explain the patient what is the meaning of not escalate the treatment at that time, because this is more and more common when the patient are older. This patient is 63 years old and it is more or less young. If we are thinking in the age in pulmonary hypertension in our days, but imagine that the patient have 65 years old, and in these cases, it's more difficult to convince the patient that perhaps she's not feeling so bad because he have enough exercise capacity to do the more simple things. But you need to explain then with calm that there is a time to control the disease. Now the disease is progressive and it will not stop the progression of the disease, and he's going to be clearly worse and he's going to have a very bad quality of life. And in this case, we are going to discuss with the patient what are the treatment options that we have, and in and give her the complete opportunity to explain the doubts and follow the choice that the patient do it for the treatment.
Thanks. So, in terms of what we can use, we now have some options for treatment escalation, either adding prostacyclin or switching therapy or adding sotatercept. So, I have a question for the audience. What will be your next treatment step? Pilar, I would like to ask you a question regarding neuroliana management. So, what would you consider for this patient? We know, according to the guidelines and treatment algorithms, that we have different choices. We can either prescribe a prostacyclin, oral prostacyclin, or switch therapy, or even add sotatercept. Can you tell us more about this?
For this patient that the double combination therapy failed and now is an intermediate high risk patient, I believe that a switch PD5 from Riothiguaz is not enough because we need to push in a stronger way the treatment of pulmonary hypertension. And it's exactly the same with Selexipac because the patient is not in an intermediate low risk, it's in an intermediate high risk. That means that Selexipac probably is not the good drug for the patient. In this case, nowadays we need to use intravenous or subcutaneous prostacyclin to treat this patient. Now, because we have a new opportunity, a new treatment, we can choose sotatercept, adding for double combination therapy for this patient that is more easy to use and with less secondary effect than intravenous and subcutaneous prostacyclin. We can have a different scenario if the patient is clearly older, for example, that we comment before, that is typical in the scleroderma patient who is 75 years old. And in this case, sure that we are going to be less aggressive. And in this case, we are going probably to choose Selexipac and no intravenous prostacyclin. And we don't have experience with sotatercept in this age. That's why probably it's going to be different. Does mean that we need to adjust the treatment to the patient and not only to the disease.
So, as you said, we now have the sotatercept, which is available. So, this is an activin signaling inhibitor, and it has been shown in phase 2, but also in phase 3 trials, so in stellar trials, that sotatercept do better than placebo. And it was very interesting to see that in this study, in both studies, to be honest, that the sotatercept has been given in patients receiving either dual combination therapy or triple combination therapy. So patients were well treated, and if you add sotatercept, they improve their hemodynamics, as you say, but also functional class, six-minute walk test, and also NT-proBNP. So we now have the possibility to prescribe sotatercept in patients treated with either dual combination therapy or triple combination therapy. So we have to consider this option, especially in patients not at low risk of death, because the treatment goal is to achieve a low risk status. But for patients not achieving a low risk status, we can consider some other therapy, including sotatercept. So, how important is MDT collaboration in the care of our patient with PAH and comorbidities, Pilar?
Well, this is key because now we are living a very complex moment. We have older patients who have a lot of comorbidities, and in some cases, it's very, very complicated to to be sure what is the proper diagnosis of the patient. That means that we need to collaborate, for example, very, very closely with neurologists when the patient have very low DDCO because he's a heavy smoker. But when you move to the CT scan, they have only very mild emphysema. It's always the same. The same question is pulmonary arterial hypertension with lung phenotype, or is pulmonary hypertension associated with lung disease? And it's exactly the same when we are talking about cardiovascular comorbidities. That means that in the end, we need to discuss in detail all the tests that we are doing for the patient to be sure what is the proper diagnosis of the patient. And then we need to consider that there are a lot of forms of associated pulmonary arterial hypertension, for example, scleroderma, lupus, etc., that we need to go with the help with rheumatologists or the internal medicine specialists to be able to give them the proper management and give them all the opportunities to control pulmonary hypertension and the other disease that they have. And especially disease, we are talking about congenital heart disease that are more complex field in pulmonary arterial hypertension because we can have very completely different scenario.
So thank you very much for this fascinating discussion. And if I want to give you the take-home messages, I would like to remind you that the treatment goal is to achieve a low risk status. So we have to assess our patients every year or twice a year. And if the low risk status is not achieved, treatment escalation is very important. And we can consider some drugs, including sotatercept, in patients receiving dual or triple combination therapy and not at low risk of death. And if the patient is very severe but on dual combination therapy, we can also add a prostacyclin, IV or subcutaneous. And for the most severe patients, they can be treated with 4 drugs at the same time. So thank you very much for your attention.